It's a great personal pleasure and privilege for me to introduce our keynote speaker. Jeff Koplan did his undergraduate work at Yale, earned his medical degree at Mount Sinai, and most close to my heart, earned an MPH at the Harvard School of Public Health. He began his career in the early 70s as a member of CDC's Epidemic Intelligence Service. He came to the School of Public Health in 1977-78 academic year with an interest in epidemiology and decision science and a desire to apply these disciplines to evaluating prevention programs. He took my course on decision analysis in the winter of 1978, which those of us who are old enough to remember was the year of the Great Blizzard. Harvard University shut down for a week. I think it's the only time that's ever happened. His term paper that year was a cost-benefit analysis of pertussis vaccination, which ultimately led to a publication, which I had the fortune of co-authoring with Jeff. Eventually was published in the New England Journal. Dr. Koplan worked at the Centers for Disease Control and Prevention for 26 years, including 4 years as its director. After the CDC, he joined the faculty of Emory University full-time. He's now the vice president for global health at Emory, and he founded the Emory Global Health Institute, which he directed until last year. Dr. Koplan has maintained close ties with China since 1980. He's an honorary professor at the China CDC and its first honorary advisor. He's the principal investigator of the Global Health Institute and of the China Tobacco Control Partnership. And he's the co-founder of the International Association of National Public Health Institutes. Dr. Koplan is a member of the Institute of Medicine and has served on its governing council, and he chairs the visiting committee of the Harvard School of Public Health. The title of Dr. Koplan's talk reflects, I believe, his exposure to both decision science and health economics while a Master's of Public Health student here in the late 1970s. So it's a distinct and personal pleasure to introduce Professor Jeffrey Koplan, who will speak on comparative effectiveness, best buys, and best bays.
Thank you very much, Milt. Better get nearer the mic. I can't help but Milt's prior comment on the double standard between prevention, public health, and costs, and clinical medicine and costs reminded me of an anecdote many years ago. It was in 1988, and it was a CDC senior staff meeting. We had a visitor who was our project person from the Office of Management and Budget, and we were discussing something we wanted more funding on, and the CDC director was chairing this meeting, a guy named Jim Mason, who went on to be Assistant Secretary for Health and Surgeon General. But the visiting person from the Office of Management and Budget said, can you do a cost effectiveness study on this thing that you want to get done? And of course, I had been working on this, and as a protege of Milt's, had been doing cost-effectiveness study, and I said, sure. I was about to say sure, when the CDC director basically knocked me off my chair and said, shut up, and said to the fellow, well, if we do a cost-effectiveness study on this, and we show it to be within the parameters that we'll agree upon for it being cost-effective and deserving support, will you guarantee then support in our budget for this program? And the fellow said, well, no, I really can't do that. And Jim Mason said to him, we're not doing a study for you. And that was the end of that particular element. But the point is that while costs are asked for, the idea of comparative effectiveness and then support for those things is slow in coming, and I'll give plenty of examples of valid, important things that have been shown to be effective and cost-effective that are either delayed or put on the shelf throughout both clinical history, but also through public health history. So it's nice to be back here. When I say these are my roots, these really are my roots, because I was born in the building just diagonally across over there, what used to be the Boston Lying In Hospital. So I couldn't get, as a colleague said to me when I was at another meeting in this building, and I said, that's where I was born. He said, you sure haven't come very far. So this has been great. I've enjoyed every talk I've heard today, which I can't say about any other meeting I've been to for years, and learned something from each one. So I thank all the other presenters because they're really terrific. It's funny that what David was saying about not having the term used, comparative effectiveness, much in his own field of injury prevention and control. And actually, it really hasn't been used much in general. And I would have to, again commend the Harvard School of Public Health, because if you go to the Harvard School of Public Health website for the comparative effectiveness area, it basically says, don't worry about the title. It's what we've been doing all along, and we do well. And it's like what works and what doesn't work, and putting a value on that. So I thought it was a very clear, unjargony approach to something that probably leaves a lot of people scratching their heads, worrying. Because when he asked me to talk about this, I said, I don't know anything about that area. And then he convinced me that he didn't care whether I knew about it or not. Basically, the area comes down to a fundamental question of what works and what doesn't work. And so while we read about it in the newspapers every day, and there are medical journals, everyone has some article in every single issue that we could call comparative effectiveness, patients, individuals, and people who live in communities are asking the same question all the time, and part of their basic interaction with the healthcare system. What works? You walk into a dentist, do I really need that full set of mouth x-rays? What do you think the science base is for that in your 1A, 1B, 2A, 2B? You need 4 or 5 down at the bottom to cover that, I think. And why do you want to extract my wisdom teeth? How many people here still have their wisdom teeth? Just a couple. Well, good. And why are they called wisdom teeth is the other part of it. But the answer I was given when I asked that question many years ago, when they were removed by a misnomer dentist by the name of Dr. Poor, was because if you don't remove your wisdom teeth, they're going to push all the other teeth closer together, and you'll end up with all of them lined up right in the center of your mouth. So take them out right away. And of course, as you age, whether you have your wisdom teeth out or not, all your teeth start moving over at some point. So there's a problem there. So that's the diagnostic part. Why are we doing this? Do I need it? And what's the problem? And then there's the therapeutic end of this. And as an example, the aging male conundrum of how to approach a difficult and serious disease, prostate cancer, with a range of options. And we'll come back to this in a bit. And then you can, of course, apply this as a lifestyle issue as well. This doesn't show up in as tantalizing a way as when it's fresh. And I thought, and I knew Walt Willett wasn't going to be here, so I thought, well, I could put this up, but I didn't count on Darius being here to judge me poorly, because if your choice is for dinner the whole wheat pasta with a liter of extra virgin olive oil, or the processed meat antipasto platter with a side bucket of lard, which you're going to choose. And it comes down to this same kind of comparative effectiveness. I had my own version of this last night when I did opt for the fried clam platter. But it's a Boston thing. And in Atlanta, they're not quite as tantalizing. So it comes down to trying to answer a series of questions. What's wrong with me when it's an individual clinical scenario, or my community when it's a public health issue, and then what can we do about it? And that's what we're going to dwell on here today. When you add a financial element to this, an economic cost, as we have in several of the things here, and we like to do, and we think that makes for a more complete picture, whether it's public health or clinical medicine, then we've got that best buys that we used in the title. And when we take a look at this and consider it from the diagnostic end, and try to improve our sense of what the probabilities are. That's the base. I just wanted to work the title in an cutesy way, but it's kind of, you know, bear with me on that part of it. We tend to think of these areas as separately, but as we've heard from almost every presentation here, you cannot really separate the public health part from most areas from a clinical overlap. So whether it's obesity and physician counseling in the office or recommendations, dietary changes, whether it's very much screening, cervical cancer screening or any other kind of screening, there's an overlap between the fields, and they're really not, to a large degree, mutually exclusive, except when it comes to funding them, as David pointed out well earlier. Just to repeat and go through that, there's a range of studies that lend themselves, provide evidence for, against, and hypothesis generation for comparison effectiveness, and many of them have been mentioned here, some given greater value than others, but at one time or another, virtually all of these have been applied to public health, the public health arena in comparison effectiveness. It's a tribute to Julio Frank, the dean, and the School of Public Health that this has become one of the initiative areas at the school. So I'd like to explore some of these interactions in clinical medicine and public health, but with an emphasis on the public health. And one way to do this, again, honoring Harvard's School of Public Health's 100th year anniversary. Initially, this was 100 years of 10 great triumphs in public health. But I didn't the easiest way to update it was to name it 114 years, because I did it 14 years ago initially. And if you've got bones to pick with the list, you're welcome to them. We can change it at any way you want to have it. And there are many other triumphs as well, but these are good ones to talk about and cover. I put them up here because every one of them has involved multiple contributions from what we would call comparative effectiveness research. And it has driven those programs to some level of success. So, well, let's talk about vaccination. And again, honoring Boston, Harvard, and its historical roots. Most of you are familiar with Boylston Street, I assume? And how many of you know who it was named after? Great. You also probably are familiar with Mather House at Harvard, and I'm sure you're familiar with who that's named after. But Cotton Mather was an influential Puritan minister. He was influenced by a slave of his who had been inoculated by smallpox virus in Africa and had thus been protected by the more serious ravages of the disease when there was an outbreak. There was a major outbreak in Boston in 1721 to 22, and through Cotton Mather's understanding of this procedure and his partnership with his friend and sometime colleague Zabdiel Boylston, a physician, they inoculated a number of people with smallpox virus. Now, when we had smallpox vaccination, we didn't use smallpox virus. We used vaccinia virus, which is cowpox, and protects and doesn't have the same side effects, because you end up getting a mild case of, and sometimes a serious case of smallpox itself when you use that virus for variolation. In any event, in an early example of comparative effectiveness, they looked at cases who had gotten variolation and those that didn't, saw a marked difference in the mortality rates, and thus advocated the broader use of this. So it isn't a new concept, comparative effectiveness. And of course, we've done this with a gazillion vaccines, all the childhood commonly used vaccines. And in virtually all of them, we have a similar pattern of what's happened. So that there is a use of the vaccine begins a sharp drop-off in prevalence and incidence of the disease, and then virtually it's virtual elimination, except for sporadic outbreaks based on misinformation about the vaccine and a lessening of our enthusiasm for vaccination that occurs periodically. Lest you think that's a subject matter of the past, Haemophilus influenza type B vaccine was introduced in just in the last few years, in the last 15 years, and we've got a similar drop-off, a disease that was really quite common in infants as a basis for meningitis, hospitalization, some deaths, and some permanent damage, has basically disappeared in this country as well. Again, it remains topical. Elements of this remain topical to today. I was at a polio eradication meeting in London last week, and a major topic of the conversation there was, when do you use oral polio vaccine, which is a live vaccine and has certain attributes and certain risks, and when do you use inactivated polio vaccine? It's the Sabin and the Salk vaccines. We're at a point now where some countries have just used inactivated, the killed vaccine, the Salk vaccine. No polio in that population. Israel's the example. However, what's happened is there is transmission of live virus, not vaccine virus, live polio, wild virus, in the sewage system. So there are people excreting it, and there is the organism is around, but the disease hasn't appeared. It means if there's any drop in immunization level, those people are highly susceptible. And so they've now gone to adding oral polio vaccine to their mix, and they're going to end up using a combination of the two over time. But an example of the continued value of comparative effectiveness, and circumstances may change, where you came to one conclusion 40 years ago or 30 years ago or a year ago can change overnight, not quite overnight, but quite short period of time when you observe something different happening in the community. Another area besides vaccination, which was one of the top 10 lists, another one is safer and healthier foods. And it's, many of you may be familiar with James Lind, who was a surgeon in the Royal Navy in the 18th century, when probably more sailors died or were incapacitated by scurvy than by military operations. And it was unclear what the cause was. But on a long voyage, you would lose seaman after seaman, and eventually significant deaths were occurring on the ship. So this Dr. Lind decided to do what some say is the first controlled trial. The statisticians present will gasp, but he took 12 people, divided them into 6 groups of 2. Confidence limits must be pretty broad on this study, and treated them with a variety of things that he had available. And it included cider, vinegar, seawater, a medicinal paste, elixir vitriol, which I had to look up as a diluted either sulfuric acid or sulfates, and lemons and limes. And after a few days, the 2 sailors on citrus fruit got better and were well enough to take care of the other 10 seamen. And he wrote this up as a treatise, published it. Some number of people read about it. But the striking thing, I think it's worth a takeaway message for us, is it wasn't for 70 years before the Royal Navy instituted this as part of their medical and health patterns. And you may see this similar pattern going on with other things that we've demonstrated either work or don't work, whether it's bloodletting, use of beta blockers in patients with myocardial infarctions when they leave the hospital, a range of things that we've been very slow to implement over time. And if you think of your own fields of inquiry, I bet you can think of good examples. And as was just discussed by the speaker before me very well, this is an ongoing thing, not just for limes and sailors, but it's true of many of the things we look at. And most recent example about a year ago in the New England Journal was the Mediterranean diet study that took a look at diets supplemented by extra virgin olive oil, mixed nuts, or just the full control group was just their regular recommendations to reduce some types of dietary fat. And the result was clearly a benefit to the Mediterranean diet supplements in this particular example. But again, can't pick up a journal any day, and there's examples, and I just got the electronic version of New England Journal yesterday and was looking through, and half the articles in them, and in it are comparative effectiveness studies. A classic one is, again, from this list of 10 great advances over the last 100 years, is the marked reduction of dental disease, improvement of oral health, largely due to fluoridation of drinking water supplies. Now, this has been demonstrated for well over 50 years now. Boston, in its Metropolitan District Commission, was one of the last places to put fluoridation in its drinking water supply, and I have dental x-rays to prove it. There are still major cities in the U.S. that have not fluoridated their water supply, and one of the things I want to touch on before we finish talking together today is what are the obstacles to the implementation of the results from the studies we do on comparative effectiveness, because there's unqualified value in the fluoridation programs that have gone on, and it makes a huge difference in people's quality of life, and yet there is continued resistance, even from cities that would classify themselves progressive in every other way, to fluoridation of the water supply. And I'll mention Portland again as an example of that. I think if I mention enough, maybe somebody will do something, but it doesn't work that way. Motor vehicle safety is an example, and I'm hesitant to say anything with David here, who knows much more than I do, but there have been some studies, as he said, motor vehicles in the injury area probably have the best database, both in terms of investment and studies that were done and in people listening to them and doing things about them. So while we can't necessarily pick out the contribution of each element in this, cars are better designed both for the safety of the occupants and for pedestrians. Our highways have been, some of them retrofitted, and new ones better designed from a safety perspective. Airbags, seat belts, et cetera, and some cost studies have been done along with it. So I think we shouldn't take second seat in this comparative effectiveness, despite what the Affordable Care Act says to anyone. It's every bit as intrinsic, if not more so, to public health as it is to clinical medicine. However, it can be quite more complicated than clinical medicine, where we can take drug A, compare it to drug B, and then look for outcome C. As we've heard from many of the talks already today, and whether it's obesity or injuries or tobacco, which wasn't mentioned, but I'll mention it a bit more, or any of the subjects we've looked at, there are many more complexities to what we do in public health and prevention than sometimes occur in clinical medicine. This works to our detriment in terms of explanation of what we're doing and the having it put into operation. But as we heard from Steve's talk at the very beginning, there are multiple factors that go into obesity. And then there are multiple potential interventions you can employ. And so, you know, that little list of A, B, C, D, E, F are some of the things you can do. You might do A, B, and C still, but then substitute H, J, and K, and it becomes more and more complicated to then determine and tease out which of these are the most important ones and what contribution each has made. Good example is tobacco control. So what are the things that promote tobacco control? Well, it's cultural norms, the social norm, which has largely changed in this country, but has certainly not changed in many other major smoking countries such as China, India. There's a psychological benefit from smoking that people perceive. They claim there's stress reduction from smoking. There's stress reduction from smoking. If you're addicted to nicotine and can't get a cigarette, then there's stress reduction from smoking. It's an image enhancer in countries in which it's the social norm, in which it's seen as glamorous, sophisticated, modern, etc. It's addictive, and there's profits to be made by important players in the community by having it. So the control measures then address some of those things, but are a myriad of approaches as well, and they include taxation, economic pressures, mass media, health education, being able to work in multiple places to provide the information to community, having smoke-free areas, making smoking inconvenient, and then changing the social norm. And all these play with each other, and so that's where your A, B, C, D, E, F is in there. Do you approach all of these, attack all of them? Are some more effective than others? And in the area of tobacco control, we have, again, limited information on this in terms of comparative effectiveness. Places that have done a good job, and I would include Australia, Canada, increasingly Europe, the US, have employed multiple things where it's really hard to tease out the contribution of any particular one, with a notable exception of the economic pressures of taxation, where there's very good documentation of the impact that taxation has had. But I would argue that you can't get to taxation and have that work successfully without some change in the social norm going before it. So you need a prepared population, which may mean knowledge and change of attitude before you can put the taxes in. And we've seen some example of that. Steve gave examples this morning of the few places that have been able to put in taxes on sugar, sweetened soft drinks. New York was unable to have an impact on its big gulp control campaign of those extra large drinks. I think it's in part because of the population needs some preparation for that. Why is it being done? What will it mean for me? Is this worthwhile? And once you've overcome that hurdle a bit, as you move the population readiness up, you can move the policy elements higher up. And you can keep ratcheting that such that, as a couple of the speakers said earlier today, in a few years we'll be doing things about obesity control which today seem inconceivable. But I think that we will be able to put in place well, who knows, predicting what goes on in the federal government is not something I want to do, but it would be hard for me to believe that these things won't be part and parcel of our armamentarium as people get ready and get more accustomed to them. And with that, the same thing applies to obesity. A range of things that we think contribute, although we can't document contribute to all of these, whether it's portion size, food everywhere you turn, snacking, marked changes in family dining habits and choices of foods, increase in fast foods, family food restaurants with high caloric intake and poor food quality in many of these, sugar-added beverages, sedentary lifestyle, decreased physical activity, all those are happening. How much they each contribute remains unclear, and then approaching each one of those is an issue. We've heard about motor vehicle injuries from David, and similar, a range of contributing factors, a range of solutions, and probably better data on many of these than others, but nevertheless, I continue to walk around thinking that driver education was a really useful thing to have, maybe just to justify the fact that I had had it and hated it. But there actually is pretty limited data. Correct me if I'm wrong. Yeah, it's down. There's little to show for it. And in fact, in a report on driver education, the quote in the report in reviewing things for this talk said, when looking critically at past evaluations, one is struck by how little they have contributed to developing and improving driver education. So, but most places still require it. So we're back to this mix. They all illustrate this difference. It's one thing to take drug A versus drug B, and we still see a lot of those studies, but public health falls in that second category, where we're looking at not just the range of interventions, but a range of outcomes that we have to look at. And when we were talking about obesity earlier today, some of the measures can be changed in BMI, but for school kids, it can also be, are they more attentive in class? Do they perform better scholastically? There can be a range of other items that make the interpretation of the intervention all the more complicated in the end. The other differences between the clinical approach to comparative effectiveness and the public health is that the clinical are often not as clear as that A plus B equals C, then the C is quite clear, then here's what we're going to do. This antibiotic is better for this disease, so we're going to take it, and that's that. So what we talked earlier about prostatectomy or management of early prostate cancer, and this is a very good article in the New England Journal about the relative outcomes from different approaches. But in reading the conclusions in the abstract, I was struck, and so I've just pulled the first sentence and the last sentence out of the conclusion. So the conclusion is, and I'm not criticizing the authors for this, this is what they found, but as either a physician counseling someone or as a patient receiving this, the conclusions are, extended follow-up confirmed a substantial reduction in mortality after radical prostatectomy. So that's a good thing. The last sentence in the conclusion is, a large proportion of long-term survivors in the watchful waiting group have not required any palliative treatment. They've been fine. So you read that and you go, I could do that, I could do that. And I was always told by folks at CDC in doing an outbreak investigation that no one wants a two-handed epidemiologist on the one hand or on the other hand. Just tell them what they're supposed to do. So here's an issue of the interpretation of even this A plus B leads to C is much more nuanced in the modern world and not so clear either. Recent examples of this interplay of public health issues and clinical care issues that we see, there's been just a epidemic of treatment studies out on chronic hepatitis C. And the comparative effectiveness actually lies within the studies themselves and then in comparison with the studies that were just published literally a couple of months before. So in the last year, we've seen a steady increase in effectiveness as one drug company after another comes out with their new version of a mix of inhibitors, protease inhibitors, nucleoside inhibitors, non-nucleoside inhibitors, et cetera, in a short regimen, which is marvelous. This is a cure. And so what we've seen is it going from 45% when just interferon was used as a effective treatment to 75% with the first group of protease inhibitors, and then boom, a couple of months ago to 96%. And then in today's or this week's New England Journal, it's 99% for a number of different options, oral medication, 12 weeks, but with a cost of treatment of $85,000. So some of you must be working on the cost effectiveness of this right now because it's a big ticket item. And for someone like me who does a lot of work in global health these days, what are the implications of all this for global health? Most of the people with chronic hepatitis C carriage are in other parts of the world. The highest prevalence in the world is in Egypt. And so no one there can afford $85,000. If the company says, well, we're going to give you a big break and we'll give it to you for $7,500, it still doesn't fly. So this is a huge, not just obviously an economic issue and a health issue, it's a huge ethical issue as well. Just reiterating the overlap that in all the talks given today here, there is that overlap. The pure public health piece or the pure clinical piece, for most of the things we really care about in important health issues, is a significant overlap in these two. There are cost issues in both of them, and so for many of the things we like to do in public health, it's large multi-year studies with a large cohort or a large population, and that brings its own costs to doing comparative effectiveness. I've done a lot of collaborations in Finland with colleagues who are responsible for the North Karelia project, and that went on over 15 years. It's still going on now. And while they've had a big impact on cardiovascular disease in North Karelia, a particular district of Finland, followed by the rest of Finland, nevertheless, it's required a significant investment. And the point being that there's, for public health, the cost of doing these studies can be very large and prohibitive to answer some of the questions we want to answer. But in clinical medicine, the same thing is true. That if you've got a new cancer chemotherapy, and the average cost of these are coming out at $100,000 per course of therapy, with a potential net gain in life years saved of 3 months, 6 months, the utility, the cost utility of these medications needs to be considered as well. But even more so, and there was a commentary in the New England Journal a few weeks ago on this subject, to do a comparative effectiveness study with one of these medications where you don't want to take the money from the company to do it is virtually impossible. Because when the medication costs $100,000 a course, and you need enough people to do the comparison of that with something else, the average cost of these studies is estimated to go from 25 to 70 million per study. So this is an issue just in terms of doing these studies, that there's a prohibitive financial factor to do them the right way, and it'll mean that there'll have to be some modifications. So in summary, this is a great area, it's a great field, we're all working in it, it goes by different names, and we'll have to continue to do it. I think there are going to be complications in doing this for both public health and at public health and at a community level, and complications of doing it the right way increasingly, particularly for in the pharmaceutical pharmacology area for clinical. We're all in this together, and the key thing is that we find the right things to do. We figure out a way to get them applied in a wide manner where everyone gets access to the things they need to do and that they're used properly. There's just as much work in comparative effectiveness and convincing people not to do the things that they shouldn't do as there is to convince them to do the things they should. So the errors of commission and the errors of omission are very much present. And I applaud the work you're all doing, and I thank you all for staying so late in the morning to listen.
Thank you so much, Jeff. We do have time for questions and comments.
Hi, thank you for a great talk and overview of all the issues. We've been talking about doing the comparative effectiveness research, but then also getting the policies implemented. And just I was curious if you could build a little bit more on what you mentioned about taxes, about that we need to prepare the population first. I'm not familiar in depth with the literature, but my understanding is that tobacco taxation started long before sort of the change in the cultural norms for tobacco smoking, which I would say is maybe 15 or 20 years old at most, that there's been a kind of a change. And the taxation was started before people were really against smoking. So do we really need to wait for that for some things to happen? And I think specifically about diet, you know, if we could get some, you know, crusading politician to pass the tax, or some crusading state or Congress to state legislature to pass the tax, I think that can precede the social norms by many years, if not decades. Do you disagree with that?
I disagree with your construct for tobacco. So the beginning, you know, one can date the beginning of tobacco control anywhere you want, I guess, because I think King, you know, Charles the something referred to it as a loathsome habit, and, you know, hundreds of years ago. But with Luther Terry and the Surgeon General's report in the 1960s began a public understanding that there was something bad health-wise about tobacco. So we had, before the taxes started to really go up, we had probably 20 years of people getting a steady diet of tobacco. Smoking is not really good for you. Here's what your lungs look like in it. So there was preparation for it at that point. Now what happens is as you start doing it, it accelerates. So we can see it very clearly in China now, where there's misinformation about smoking. Lots of surveys, there's lots of myths about it, that the biology doesn't apply to us, that it actually helps focus your mind. If you're working hard in a project, have a couple of cigarettes, it's good for it. I mean, there's a lot of that stuff. So you can see the change and the need for that. So I'd say for tobacco, You had that information. But, you know, it's happening in obesity. People are getting the information now as well. If you ask, and what's happened with tobacco is people who smoke are in favor of more controls now, which never would have happened before that. So they work together. I think, you know, in some places, if you come, and China again is a good example, which is in projects I was working on 15 years ago, there were policies implemented at a local and national level that were anti-tobacco. You can't smoke in government buildings, you can't smoke here and there, and they were never enforced. And now, with a better understanding in those places of some of the problems, enforcement is beginning to be seen. So I think they can add up. Your point of, can you leapfrog that and maybe do some of the economic stuff even before that settles in? I don't know, it may be possible. But, you know, we got an example going on in Mexico right now, that the changes in taxation on, they're grappling a little bit with what they're going to label as high energy foods and, you know, and sugar sweetened beverages. But that's going on, and it's going to be evaluated. And hopefully from that will come some understanding, and that could influence places here that might be able to implement the same thing. The big advantage we have is we're a heterogeneous place with a lot of different states and municipalities, and so some places, you know, will get out in front and try one of them. If it works and you see some change, then that encourages the others to do it. So yes, I do agree with you on the latter part of what you said. Thanks.
Thank you. I'd like you to comment on the downsides to myopic comparative effectiveness analysis. As I had mentioned earlier, on roundabouts, we think they're great because they've improved driver safety and they've improved pedestrian safety, but they've increased the danger for bicyclists. On cars, the design of the cars has increased the safety of the car occupant and also of the pedestrian, but because the bonnet was raised so that the pedestrian bounces off the front hood, so that the belt line was raised also for streamlining, but also to better protect the other car people in the car. The roll bar was raised, all of this raising the back window, also the headrests were raised. It greatly improved the safety of the car occupant, but it greatly increased the danger for the bicyclist. So that comparative effectiveness analysis for the car design improved the safety of the car occupant, but increased the risk greatly of the bicyclist. So again, looking myopically at only car occupant safety, pedestrian safety, and design of the vehicle, how do you have that cost effectiveness, comparative effectiveness extend to the other populations?
You've got to decide how important cycling is in your community. So I'd be the last person to say it's not important and we don't want it, but that ends up being a reflection of how important that is in the community. Now part of it may be folks just not recognizing or thinking ahead or considering all the parameters, and certainly that wouldn't happen, I think, as you indicated, in the Netherlands or places that have, or Copenhagen, which has highly pro-cycling public policies, but it's what you value. It's the value system of our elected official. It's the value system of those that put it into play. And in some things that we do that we think we're doing good, we don't realize that there's a downside to them later on. But your point's well taken. It's balancing out all these different needs.
Well, let me once again give a deep felt thanks to Jeff Koplan for taking time out from his busy schedule, traveling up from Atlanta. So let's give another round of appreciation.